Hello everyone, welcome to my channel. The topic of today's video is UTI in pediatric. How to diagnose UTI in pediatric and what are the primary treatment or what are the drug of choice we can select in the UTI for the pediatric cases. We are going to discuss that. So UTI is of two types. First one is a cystitis and second one is a pyelonephritis. So cystitis is confined to the bladder only, and pyelonephritis is confined to the renal parenchyma. It is a infection of a renal parenchyma. Okay, so these are the two types. So what are the causative organisms? The E. coli is the most commonest and most famous organism that causes the UTI, but the rest are also important. Klebsiella, Pseudomonas, Enterococcus, Staphylococcus, and Saprophytis. Then S. epidermis. These are also important as far as the UTI is concerned. So the Proteus is the pathogen in the uncircumcised boys, and the group B, Staphylococci, is the most commonest and the most important organism that causes the UTI in the neonates is a group B, streptococci in the neonates. Now the clinical presentation in infant. The clinical presentation are as follow: the poor feeding, vomiting, diarrhea, irritability, jaundice, and seizures. These can be present. And the symptoms in the 1 month to 2 year babies, there are the symptoms like fever and some urological symptoms like changes in avoiding patterns and the foul smelling urine. In a preschool children and a school age children, the specific urological complaints like urgency and dysuria, suprapubic pain, hematuria, and enuresis, these are the symptoms in a preschool children or a nursery or a KG kids. Urological symptoms are those, and non-specific symptoms are like abdominal pain can be present and a vomiting can be present. But if there is a higher fever up to 101.3 Fahrenheit or a 38.5 degrees Celsius or flanks tenderness and systemic toxicity, then we can consider our diagnosis may be a pyelonephritis. Then how come we can get the diagnosis? So for the diagnosis of UTI, the amount of bacterial growth required is the less than 10⁻⁵ CFU per milliliter per ml in a mainstream clean cast urine. This definition is a statistic one and indicated 80% of the true infection chances. If we take a culture and with a pure growth of about 10⁻³ CFU per ml for the suprapubic sample and 10⁴ in the catheteric sample, there can be a symptoms with the symptoms of UTI can also indicate the infection or can also confirms the diagnosis. Then the third thing is the promoting prompt planning of the specimen is important to meticulous cleaning of the perineum and urethral meatus for reducing the frequency of the false positive urine culture. Sometimes this happens that if the patient has not have the clean genitals, and if there is diaper rashes or some other infections, sometimes the girls, adolescent girls, not they have the vaginitis or any other infection related to the genitals or urinary tracts, so there can be a growth of organisms, and that can be lead to the false diagnosis. So before collecting the sample, you can you have to clean the perineum and the urethral meatus for reducing the frequency of the false positive urine culture. If the specimen cannot be plated immediately, store it at a 4 degrees Celsius 4 degrees Celsius refrigerator or 39.2 degree Fahrenheit to prevent the growth of a contaminated bacteria. If the sample is collected at night and if the lab is not a technician laboratory is closed, so for that you can store it at 4 degrees Celsius or a 39.2 degree Fahrenheit to prevent more growth of the bacteria. It can lead to the misdiagnosis, or it can lead to a false diagnosis. So urine bag sample is not collected. It's not sure. It not give the surety of that the bacteria and the urine sample is not perfect for the diagnosis of the UTI. In UTI, the protein urea, hematuria, and leukocyte esterase should be positive in the deep stick test, and the deep stick test for nitrates has a lower sensitivity in infants and younger children. So for that, due to frequent voiding, because they have the urgency and they frequently void, so in infants and the younger children, we can't rely on the deep stick test for the nitrates. Urine must remain at least 4 hours in a bladder to produce the nitrate by the bacteria. Gram positive organisms does not convert nitrates into nitrates, so the deep stick test will always be negative for nitrates in the deep stick test for the UTI. WBC is present that in a urine analysis. If the WBC is present, it can lead to a diagnosis of pyelonephritis. Then if the WBC is greater than 15,000 per mm cube, the sedimentation is greater than the 30 mm per hour, or CRP is there. In CRP, if there is an infection, we can diagnose the UTI, or only symptoms of the UTI are not significant for the diagnosis of the UTI. There should be dysuria, frequency, urging with the suprapubic tenderness, with gross hematuria or without hematuria or bacteremia. These symptoms can lead to the diagnosis of the viral cystitis or idiopathic hypercalcemia, calciuria. Some findings with the pyuria but no hematuria are compatible to dysuria, pyuria syndrome or acute urethral syndrome. Symptoms of the vaginitis or balanitis can mimic the UTI. So the negative urine culture are necessary for confirmation of the diagnosis that it is not a UTI. It can be a vaginitis or a balanitis. Then, considering a UTI this is a general advice that if you are dealing with the infants or any kind of a kid up till 25 or 26 years, so consider UTI in all the children under the 2 year of an age with the fever, and girls of any age. Mark my words, girls of any age with a fever or without identified source for more than 2 to 4 days of fever, consider UTI and do urine analysis for that. Okay, let's come to the emergency department management. How we deal in the ED these kind of cases. Presence of a large number of epithelial cells in a specimen is suggested for the contamination. In infants, finger tap method is used. E. coli is resistant to antibiotics. Which are the antibiotics? The E. coli is resistant to trimethoprim and sulfamethoxazole, amoxicillin, ampicillin, and first generation cephalosporins, that is a cephalexin. Then for the treatment of UTI, you can give amoxicillin and clavulent, that is in a dose of the 45 milligram per kg per day in a divided dose of 12 hourly. Then empirical treatment is a cefixime 16 milligram per kg per day, divided dose over 12 hourly, followed by 8 milligram per kg per day, divided dose of 12 hours. Then followed by that 400 milligram per kg per day maximum dose should be given. Or cephedrine 14 milligram per kg per day, divided dose of 12 to 24 hours, or 600 milligram per day maximum dose you can give. For treatment of the UTI, the course of medicine should be given for the 7 to 10 days. Treatment of the afebrile non-pregnant adolescent girl and a uncomplicated lower tract infections less than for the 3 days, you can give the ciprofloxacin 250 milligram bid for the 3 days, oral phenoxyperidine or peridom 4 milligram per kg per dose for the short term use of under 2 days in children 6-year-old onwards. This should be given to only the 6-year-old or onward children with the symptoms, if there is a symptoms of the burning and urging and increased frequency of the urine. Now the treatment for the IPD cases. If the infant is 4 weeks of age, then ampicillin should be given. If the age is 1 week of if the child is a 1 week of an age or infant, so we can give the 100 milligram per kg per day, divided dose of 12 hourly of ampicillin. And if the age is 1 week of age, if greater than 1 week of an age, so then 200 milligram per kg per day, divided dose of 6 hourly cefotaxime. For the dose of the cefotaxime, if the infant if the age of a patient is less than 1 week of an age, 100 milligram per kg per day in a divided dose of 12 hourly. And if the age is 1 to 4 week of a patient, then 150 milligram per kg per day, divided dose of 8 hourly. If the age of a child is more than 4 weeks to 3 months of an age, admit the patient and start the treatment with the ceftriaxone 100 milligram per kg per day with a divided dose of 12 hourly, and advise CBC, blood culture, complete full sepsis workout if the infant appears ill. Now the last thing, if the age of a child is more than 3 months of an age, then admit and start the treatment with the ceftriaxone 50 milligram per kg per day. And indications for the admission in the IPD are the symptoms are toxic appearance of the patient, inability to tolerate the oral intake including antibiotics. If the patient is not tolerating the food or water or any kind of food, dehydrated patient, immunocompromised, and risk of the pyelonephritis. And if the patient have the high grade reflex abdominal UG anatomy. This is all about the UTI and the treatment plan of the UTI in the pediatrics. Thank you.